So a diabetic, patients with chronic kidney disease, known stone formers, and as I mentioned, patients with persistent hematuria post-treatment of infection, you will obviously will guide your diagnostic workup based on what you find. In terms of doing a PSA, as usual, PSA is controversial, and the recommendation is that PSA can actually be omitted in your initial workup prior to treating bacterial prostatitis, unless, of course, there's other compelling reasons to perform the PSA. So if there's a strong family history, or you have findings on your rectal that would warrant doing a PSA. And that's really it for chronic bacterial prostatitis. When we move on to chronic pelvic pain syndrome or chronic prostatitis, the type 3 prostatitis, the definition is pain and discomfort in the lower abdomen and pelvis for 3 to 6 months after excluding other causes. So again, it's really a diagnosis of exclusion, and investigations are aimed again at detecting those causes. It is a type 3 prostatitis, and it will fit into one of the two types, either the inflammatory or non-inflammatory, and that will be based on your VB3 of the 2-glass test. So whether there's an increased number of leukocytes on your VB3, we'll call it inflammatory, and if there's no increase in leukocytes, it will be non-inflammatory. Doesn't really affect management that much, but you would have done the 2-glass test anyway to exclude bacterial prostatitis. So it is, you will have that information anyway. The etiology is multifactorial. That picture doesn't project very well. I suppose I should have paid for the software and not just jippered it. So what's the proposed etiology is that there's normally some sort of induction or some initiating trigger, whether it's infection or toxin or stress or trauma, which starts an inflammatory response, and then there's facilitation of that inflammatory response via inflammatory pathways. It becomes propagated via immunological and neurogenic pathways, and basically becomes almost a neuropathic kind of pain disorder. And there's a lot of overlap between chronic prostatitis and your other chronic pain syndromes, such as irritable bowel syndrome, migraines, fibromyalgia. Yeah. So these are, again, some of the proposed mechanisms or proposed causes. In terms of infective causes, less than 8% have been found to have the common uropathogens, but there is an association with a bacteria called Burkholderia cenocepacia in the urethral sample, so in your VB1 or VB2, I forget now where we are with the VBs, but anyway, so there is an increase, there's an association with this bacteria. They also say that in terms of your urogenital microbiome, that patients with chronic prostatitis tend to have increased biodiversity in the urinary tract and decreased biodiversity in the in the gut, and that there's some proposed maybe mechanism there. Inflammation, less than a third of these patients will actually have proven prostatitis on a biopsy, and there's poor correlation between the signs of inflammation. So even your VB3 won't necessarily have a lot of leukocytes. There's a very poor correlation between severity of disease and evidence of inflammation. Neurogenic causes, it's felt that there is sensitization of both afferent and efferent neurons supplying the urogenital tract. And basically, this results in ongoing neural activity, even in the absence of noxious stimulation. Then there's pelvic floor dysfunction, where there's spasm of the muscles of the pelvic floor, which contributes to the pain that the patients experience. And then, quite importantly, is the psychosocial factors. We all see these patients, and often we become a bit exasperated with them because they do tend to be a bit helpless, and they are a bit catastrophic, and they catastrophize everything. And we're often the last resort, and they've been sent to us by the gynaes, or they've been sent to us by their GPs who've tried everything anyway. And now we're kind of expected to sort them out. And so psychosocial factors are quite important, and there is a lot of association as well with mental health illness and depression and anxiety conditions. So as part of your assessment of these patients, you should perform a formal psychological evaluation. Well, not us, presumably, we can send them to the psychologists for some assistance in that. There are some interesting endocrine abnormalities. There's felt that patients have got higher stress hormones, they've got increased cortisone, morning cortisone with decreased ACTH. So there's some sort of activation of the HPA pathway that's not fully understood, but it does seem to be an association. And then genetics seems to be important because of so much overlap with other conditions and pain conditions. And then there's also the concept of abnormal sensory processing, where some patients are just more sensitive, and not in like crying in a movie kind of sensitive, like they just have maybe like a lower pain threshold. And so yeah, they found that some of these patients have got sort of low pain threshold compared to normal peers. So this is what's been devised as one of the ways of evaluating these patients. It's called the U-point or Snowflake hypothesis. So what it has is 6 clinically defined domains, which include all of those pathways that we discussed. And you'll plot your patient on the Snowflake and see how many of those domains he or she occupies, as well as how far out on the domain the patient is. And the more domains that are involved, the higher the likelihood that the patient has a chronic pelvic pain syndrome. Whereas patients who have a discrete cause for their pathology, such as a prostatitis, a bacterial prostatitis, or a urogenital malignancy, will tend to only be focused on perhaps 1 or maybe 2 of the domains. These are the different elements that make up the 6-pointed star, even though there's 7, and U-point suddenly found an S when they transcribed it to the EAU table. So the urology phenotype or urology pathway, we need to assess the urinary flow, micturition diary, you might need a scope, ultrasound, uroflowmetry. Psychology, we discussed, patients often have anxiety about pain, they have depression, they have associated negative sexual experiences. There are some organ-specific conditions that can also cause pelvic pain in the vicinity, in the perineum. So there's gynae stuff, there's anorectal pathology, specific infections in the urogenital tract unrelated to the prostate. So patients with orchitis, epidermal orchitis, can also present with pain. The neurological complaints, patients who've had previous CVAs, patients who have any other sort of history of neurological disease. And then it's important as well, I'll show you a diagram now about, we spoke about the tender muscle, the palpation of the pelvic floor pathology, pelvic floor dysfunction. So there's some trigger points within the pelvic floor that can be palpated for and might be contributing. And then, as I said, the U-point got an S, which involves your assessment of the patient's sexual function. Further to your evaluation, which also helps with sort of following patients up, is the National Institute for Health CPSI. So that's the Chronic Prostatitis Symptoms Index. And what they've divided the symptoms up into 3 sort of categories, where the 3 domains are pain, lower urinary tract symptoms, and quality of life. So the first 4 questions relate to pain symptoms. The next 4 questions relate to avoiding symptoms. And then the last question is about quality of life. And generally, the higher the number of pain locations in the first part of the questionnaire, it correlates well with the greater severity of the disease, and as well as what they perceive as poorer quality of life. Urinary symptoms alone don't really correlate with reduced quality of life. So it does seem to be that CPPS is more of a pain condition and less of a urinary condition, urological condition. So as we said, history. So this history will include all of those validated questionnaires between your CPSI and your U point. Examination is important. Good genitourinary examination, examination of the prostate and pelvic floor, and abdomen, low abdomen, and then some lab investigations, your urine dipsticks plus culture plus your 2-glass test. So this is the diagram for the male pelvic floor examination. So the little star is the anus, the blue circle is the prostate, and then the numbers represent kind of the dials on a clock, numbers on a clock, and you can work your way around all of those trigger points to assess for sensitivity, and then it correlates with specific muscle groups. And patients who have that sort of tenderness might be good candidates for physical therapy going down the line. I think Dr. Mayer will discuss treatment options more than I will. So yes, we said the special investigations, your 2-glass test, which is your VB2 and VB3, uroflowmetry, ultrasound, cytology if indicated, and again, aimed at looking for and excluding other causes. And once we've left with nothing else, then we can call it chronic pelvic pain syndrome. This is just an algorithm for the management and treatment. You can have a look at it in your own time, but it's got a lot of stuff about it's whether they respond to treatment or don't respond to treatment, and what your workup entails. So yeah, that's it. Unfortunately, chronic pelvic pain is still quite poorly understood. It's extremely complex, and it remains very debilitating, in spite of maybe our attitude towards it. We do tend to become a bit flippant and blasé when we get these patients, and we just don't know what to do with them, and their scopes are normal and their PSAs are normal, and we don't know what to do. So it's important to include in our workup those questionnaires, those validated questionnaires, and look for potential treatment options that we don't normally consider as urologists. And so a multifactorial, multidisciplinary approach is required both in the workup and the management of this condition. We've got most of my stuff from Campbell's and the EAU guidelines, and then an article that Prof sent us, which is Diagnosis and Treatment of Chronic Bacterial Prostatitis, just a consensus guideline from 2015 from the BJUI. And that's it.
Lucio, thank you very much for your excellent presentation this morning. I'd like to open it up to questions from the floor. Please, you can just raise your hand, and then I should be able to see that and let you have a comment. I've always found the National Institute of Health classification system very useful. Are you familiar with that? It's quite nice to put patient into that classification.
Those 4 types that we mentioned, yeah, which are actually 5 types, but 4.
Yes, exactly.
Yes. Yeah, so that is useful. Obviously, we didn't talk about the acute prostatitis because it wasn't really in the scope of this talk. And type 4 is really just a histological diagnosis, incidental histological diagnosis in asymptomatic patients. And then the only real things you need to discriminate is the one that is bacterial. So you'll find that on your if you do your 2-glass test, and the ones that are inflammatory versus non-inflammatory. It doesn't. I don't know how much it affects management. Apart from obviously, if it's a bacterial cause, then it will affect our management. But if it's just between the non-inflammatory and inflammatory, the 3A and 3B, it's really an academic discrimination. I think it doesn't necessarily affect our management.
I've always been a bit concerned about us missing a infectious cause, and I think that's partly because I missed the big take-home message, which in most cases is not infectious. But did you come across anything in your reading that suggested that you do the VB2 and 3, and you attempt to get some secretions that you can send away, but that's just going to give you ordinary culture? Should one be doing amplification testing, PCRs for some of the less easy to culture? Is that advocated?
Not really in any of the guidelines or recommendations. It is that kind of in the academic stuff. When you read the text in Campbell's, they do talk about a bunch of these other bacteria. I mentioned the one. Where is it? I can't even remember the name. That Burkholderia Cenocepacia. So there might be a bunch of bacteria that we're not typically testing for and culturing. But yeah, it's not. It seems like at the moment it might not be worth. I don't know if it's cost effective to go and chase these things. Although, if there aren't many other treatment options, you run out of options pretty quickly with these patients. Maybe it is worth investigating. I don't know.
Sure. And it's not an uncommon thing for us to see the category 4, which is asymptomatic inflammatory prostatitis, on a biopsy. Is that something that we should be chasing a symptomatic diagnosis with? In other words, they may in fact be symptomatic, or is it something that we just should ignore?
Well, I think we probably, you see, if we become better at using these validated questionnaires, we might pick up more symptoms than we are. I mean, we just tend to ask the patient, "Are you peeing well?" And then they say yes, and then we leave it at that. So there probably is a lot of asymptomatic patients that are symptomatic, whether it be sexual dysfunction or premature ejaculation or those kind of conditions, or painful ejaculation. We don't ask necessarily, unless you're using those questionnaires, then you're going through a template. It's not something you really ask unless the patient's forthcoming. So there might be a bunch of patients that asymptomatic group might be smaller than we think. And there may be a bunch of patients that we're not picking up because we don't really ask enough questions.
And the guidelines would recommend the 2-glass test, in the sense that I think I've perhaps been a bit lazy and simply...
I think we all are.
But they are encouraging you to chase that
yes.
degree of investigation.
Most of the recommendations include doing that as part of the workup. Over like more than just a normal urine MCNS, which we kind of all do, but yeah. I know that I don't know about the younger guys. I don't know how many prostatic massages we do really. It's not really something we practice much in our clinics. I don't know what the other guys think. I know it's more of an old school thing. It was almost like a therapeutic thing in the past. But yeah, I mean, it is definitely within the recommendations and the guidelines. So we probably should be practicing it more than we are.
Sure. I see that we've got some colleagues from the private sector here, particularly Dr. Steve Eppel. I see he's joined us. I hope I'm not going to embarrass him too much, but I know that he has an interest in this, and diagnostically, these patients can be quite a challenge. Steve, I don't know if you would like to join us and just comment on the diagnosis of these patients. We're going to get to the treatment shortly.
Thank you, John, and everyone. Yeah, I was going to reserve my comments to the very end to see what the doctor is going to be talking about treatment. But with regard to the pathogenesis and the presentation, firstly, obviously, you've mentioned, everyone, and Dr. Lucio has mentioned that the non-inflammatory pelvic pain type presentation is the most common. So, and certainly in private, we see that's the condition we see. We see chronic pelvic pain rather than an infective process, and that's the common presentation. And many researchers believe that the central pathways, the neurobiological and the psychological pathways, lie at the core of the pathogenesis. And we, as end organ doctors, are not really trained and not really interested in viewing the patients in that way. So the multidisciplinary approach becomes very important. But those of us who are interested in this area need to remain interested, because we're going to be seeing those patients. So it's complex. Certainly the excluding urinary tract infections, the VB, whatever you want to call it, that's confusing. But I think prostatic massage with collecting urine samples is important, but you know, most of the time you're not going to find anything. So that's the point I wanted to make. But I'm interested to see how you all approaching management, and we can perhaps comment after that.
Thank you very much, Steve. Lucio, wonderful talk this morning. Thank you very much for